Morning all. Glad you could make it, given the morning. So, the evidence. So declarations, I do off-pump surgery pretty much exclusively. At the minute it's just shy of 99%. I train, I'm a proctor and I'm published, so I'm going to try and be non-biased, but that may or may not be possible, unfortunately. So, the evidence, what is it? Well, it's controversial. Everyone has their own view on what's in the literature and how one should interpret that, unfortunately. And those that do interpret are very opinionated, as I suppose I am too as well. And I think the most important thing to think is that it's muddy. You know, what is in one study and one group of studies isn't in the others. So, broken into two different types. But when you look to see what's there, how many references there are, I did a PubMed search on Friday. So, we've got 36,000 references for cardiopulmonary bypass, of which 3,000 are review articles. 65,000 for CABG, of which nearly 6,000 are review articles. 7,500 for off-pump, 600 review. 900 comparing the two, 65 are review. Now, I did these searches in May of last year, 10 months ago. So that works out at 3 new references per day about cardiopulmonary bypass in the last 10 months. This is a very active field. There's no way one can know all of this. So what I've gone through is certainly in no way exhaustive, because it's just not possible to be exhaustive, quite frankly. So 2 types of data, randomised, non-randomised, and I'll do the non-randomised first. So these are generally large data sets, retrospective. And there are attempts made, various fancy statistical tests, to try and match the groups to get some additional, more pertinent information from them. But they have all the usual problems that retrospective studies come with. So, 2001 to 2004, Hannon and his colleagues looked at the New York State patients, large groups, 48,000 patients. And basically they had superior short-term results and similar results at 3 years of follow-up data. If you include revascularization, on-pump was superior, but that's the early 2000s. Similarly, in the early 2000s, they were doing the same thing on the other coast of the States, larger numbers, 58,000 patients, lower crude mortality, lower matched mortality. Interestingly, a 6.2% conversion rate. Keep that number in your head as we go forward. BHACAS has done a lot of work on off-pump surgery. He's done, I think, nearly 3,000 cases himself. So again, like myself, he's probably not in the equipoise group. So a little later in the early 2000s, and they felt that volume might be an issue. So they looked at centres doing more than 100 coronaries off-pump and 100 coronaries on-pump, and that excluded over 90% of the units in the States. They had a total of about 42,500 patients. And these showed lower crude mortality, lower matched mortality, lower morbidity, and a lower conversion rate. So a third of the conversion rate of the centres that were doing smaller numbers as well. And it's fairly clear, you know, death, MI, stroke, combined morbidity score were all significantly better. Looking at his own hospitals, 3 Emory hospitals over a 10-year period, with a total of 17 surgeons, comparing on-pump and off-pump, 14,500 patients. This was the classical graph that I first saw when I went to Liverpool up on my boss's wall. It showed lower mortality with higher risk patients. They broke it into 4 quartiles, and the lowest 2 quartiles had the same outcomes, off versus on. The upper 2 quartiles had improved mortality with off-pump surgery, and that improved as risk went up. Again, a low conversion rate. And that graph is fairly, classical for the results. They did it again, same group, different lead author, looking at the SCTS database over a period of 5 years, looking at sites that are performing more than 300 cases over the study period, which was more than 50 cases per year. Which was a little less restrictive and meant that 24% of units could be included, not just the 9%. Huge numbers, approaching 850,000. Again, lower mortality with high-risk patients, and a slightly fancier version of the same graph, effectively, showing that throughout the risk profiles, off-pump surgery was superior to on-pump surgery, and that gap appeared to increase as the risk increased. So that's all been the US. What about our homegrown stuff? This is the study I was involved with. We looked at all of the outcomes from a 14-year period. About 40% of cases are being done off-pump of those 13,500 patients. And the off-pump cases were generally a little bit higher risk, had lower short-term mortality, and slightly better morbidity. The outcomes were identical, and the conversion rate was 1.3%. So that's outcomes over time, out to 13 years, they completely overlap, and the graph is effectively identical for adding repeat revascularization as well, which is commonly known as the bugbear. Interestingly, if you split it into single, double, and triple vessel disease, left to right, the single vessel disease showed superior outcomes long-term with off-pump surgery compared to on-pump surgery. Not entirely sure exactly what that would be down to, but it was a fairly clear signal in our data. More data from Bristol this time, looking at a 20-year period, single institution, and they concentrated on diabetic patients, so quite a large number of diabetic patients going through. And they had very good results. Lower early morbidity, similar mortality, and identical 1, 5, and 10-year outcomes. Very low conversion rate, 0.6%. It was only 7 patients, and none of them died, which is marvellous. In our own data, we had a 10% mortality rate with converted patients, which is pretty much what you see across the literature. So they did very, very well with these patients in Bristol. And that's the graphs, on versus off, overlapping through time. This was published, I think, about 6 weeks ago. Huge study, 8 years worth of US inpatient data, nearly 2.1 million patients, 1,000 hospitals, and it comprised coming from 43 of the 50 US states. And looked particularly at the outcomes versus volume. So high volume, low volume. What was very interesting was what they defined as high volume. So they broke it into quartiles. So for the surgeon, the median was 29 cases. The highest quartile started at 48 cases per year. The lowest quartile was 6. If you were doing more than 48 cases per year off pump, your risks were lower than on pump surgery. If your hospital was a high volume centre, so high volume was, the highest quartile was 164 cases per year. The lowest quartile was 29 cases per year. So if you were doing 164 cases a year or more in your hospital, off-pump surgery outperformed on-pump surgery. The flip of that was if you were in the lowest quartile, off-pump surgery was worse in your hospital than on-pump surgery. And if you were a low-volume surgeon, off-pump surgery was worse for you than on-pump surgery. Quite clearly, if you can do it, do it. If you can't, don't. So, to the randomised data. These are generally a lot smaller. There's variable quality. We'll get to that. And the results are mixed. Again, Bristol, they started off pump surgery around the same time as Liverpool and have done lots and lots of work on it. So BHACAS, they did 2 studies. The first was looking at LED and PDA. The second included the circumflex as well. And they combined the two and published them as a sort of a small meta-analysis. And effectively, they had lower early morbidity and identical outcomes out to the medium term. They didn't really define exactly how far it was. The first study was a median of 25 months. The second study was a median of 13 months. And they talk about 1 to 3 year outcomes. Seems entirely reasonable. ROOBY. Good study. Started 2002, 2008 for the enrollment. 2,200 patients. It was the VA system in the States, so virtually all male, and they were quite young patients. The average age is less than 63. The 30-day results were similar. The 1 and 5 year results show inferior outcomes with off-pump surgery, and they were both published in the New England Journal of Medicine. The graphs are fairly clear. Off-pump is not as good as on-pump. However, surgeons were inexperienced. To be an off-pump expert in this group, you had to have done 20 cases, and the median number of cases done for the surgeons was 50. At a high conversion rate of 12%, If you look back at the previous studies, 6% was the worst in all of the observational data. The US average at the time, depending on how one defines it, was either 4 or 6 times the US average at the time. And very interestingly, if you look at the sensitivity analysis, where they take these patients that have crossed over and analyze them in a non-intention to treat way, their p-values go away. There's no significant difference between the groups. That last bit of information gets lost. ROOBY gets lumped in with lots of things, and they forget that actually they disproved their own hypothesis. Coronary trial, a little later, 2006, 2011, international trial. I think it was 19 countries, 79 centres, 4,500 patients, and showed some aspects of morbidity were lower at 30 days, but primary outcomes of death, MI, etc. were the same at 30 days, 1 year, and 5 years. Revascularization rates at 30 days were slightly higher, but that was lost at 1 and 5 years. Interestingly, the surgeons here had to have performed a minimum of 100 cases. The ART trial, pretty good study looking at single mammary versus bilateral mammary, and it isn't set up to look at off-pump surgery, but a significant proportion of the patients are being done off-pump surgery. So although it's only post-hoc analysis of these 3,000 patients, it is reasonable to look at it. Similar 30-day and 1-year comparisons for off and on-pump surgery. There's no 5-year off-pump data yet. The 5-year single versus bilateral mammary data is out, and that's caused consternation. But that study showed exactly what it's supposed to. No difference at 5 years. It's powered for 10 years. And it'll be interesting to see if Professor Taggart can give us any insights, because he's here this week. CABG, German study looking at older patients. This is the first randomised trial looking at the patients we think might be best served by off-pump surgery. Again, fairly contemporaneous, enrolling from 2008 to 2011. 2,500 patients. 30-day, 1-year mortality and MACE are similar. And the repeat revascularization, again, like previous studies, higher at 30 days, but that signal is lost at 1 year. Their 5-year data should be due quite soon. I've heard rumblings about it, but I haven't actually seen anything myself, unfortunately. And their graphs are fairly obvious that off-pump is better, but doesn't really reach significance. Interestingly, they had a median of 322 off-pump cases and an average of, I think it was 514 cases per...
Sorry, Andrew, you got 1 minute.
Righto. They convert quite a lot, but that's a lot of it is to do with the design of the study and the surgeon not being available. Non-touch technique looks like it should be it should give better outcomes as well. 37,000 patients from 13 studies, meta-analysis from 1988 to very recently. Stroke, mortality, renal failure, bleeding, AF are all improved, but not myocardial infarction, and that means not touching the aorta is good for you. So in conclusion, there's discord. There's clear evidence of experience of the unit and the surgeon being important, and the clear evidence that reducing manipulation of the aorta is also beneficial. I think most benefit, there's small benefit for most patients, and the most challenging cases are the ones you're going to get most benefit. I mean, who's going to want to clamp that? You do that without touching anything if you can. And it's best not to reserve off-pump for these cases, because you don't want to be doing the difficult case a different way. So multiple arterial grafting and not touching the aorta is probably the best way to go.